start recording. And then, okay, is everyone getting the permission to record thing? Okay, so we're just going to go ahead and I'll call out people's names and we're just going to start with some simple questions. So I'll have you guys introduce yourselves, say where you're from, what year of residency you're in, and the first question will be, what made you choose PM&R? So we'll start with Brian.
Hey there. So my name is Brian Cerboni. I am currently a third year PM&R resident at the University of Washington. And I'm originally from Puerto Rico, which is where my background's from, San Juan, Puerto Rico. So the next question, I suppose, is how would you describe PM&R, or why did I choose PM&R?
So the question is, what made you choose PM&R? But if you would like to describe, yeah, go ahead.
Oh, no, it's totally fine. So what made me choose? So in Puerto Rico, the huge difference comparison to here in the United States, PM&R is actually really well known. We grew up knowing what a physiatrist is, mostly outpatient musculoskeletal, though, not necessarily the neuro rehab part. So growing up, and once I decided to go into med school, I kind of had an idea that I wanted to practice outpatient musculoskeletal medicine. And I actually only thought that it was through PM&R. It was a surprise to me, actually, that people here in the United States, in the mainland United States, do so more so through family medicine, or not even having gone through PM&R, excuse me. So that is why I was leaning towards it, and ultimately chose the career path.
Thank you. Next, Sarah.
Okay, so I'm Sarah. I'm one of the second year residents. So I grew up in Texas, but my family lives in New York now. I guess in terms of why I picked PM&R, so kind of similar to, I think, a lot of people in the field. I initially thought I wanted to do ortho, but during my rotations realized that OR is not for me. And then kind of going through, I found that, I liked neurology, internal medicine, and kind of finding a field that kind of combined all of my interests. I actually stumbled across PM&R. That's kind of how I ended up in the field.
Thanks, Sarah. Amar?
Hey, I'm Amar. I'm from Texas originally. My story's a little convoluted. I was actually in dental school about 10 years ago. Ended up having limb loss. I lost my arm in a car accident. So I actually got introduced to it as a patient first, as I was trying to get my prosthesis, and I transitioned into medicine. Luckily, I had that experience because my school actually didn't have a PM&R program, and so through kind of my experiences that I got to know more about it. I like doing more general neuro rehab, probably more inpatient or consults, which is not as typical or the popular route right now.
Thank you. Katie?
Hey guys, I'm Katie. I'm also one of the R3s, originally from Pennsylvania, but came out here intern year and then stayed for the PM&R residency. So I guess I'm more on Brian's route. I found PM&R, sort of stumbled upon it, but because I was interested in doing musculoskeletal medicine, I went to a DO school. So we did a lot of I don't know, everybody gets anatomy, but we did a lot of osteopathic manipulation. So I really liked sort of the biomechanical stuff. And then once I found out about rehab and sort of saw it as a residency where you obviously get a lot of medical, general medical training, but more focused on that musculoskeletal and neuroanatomy than if you went into a family medicine practice or internal medicine practice to get into a sports sort of fellowship. So I was more interested in that. And now I'm applying for sports and spine fellowships. So not really a pain fellowship, not really a sports medicine fellowship, but a little bit somewhere in between.
Thank you. Allison?
Hi, I'm Allison. I'm from California and I'm a R2. I found out about PM&R before med school when my brother was diagnosed with Guillain-Barré syndrome and he was hospitalized in the inpatient rehab. And he recovered now, but then I went into med school thinking I wanted to explore the field of PM&R. I found I really liked learning about the brain and the musculoskeletal system, just really made a lot of sense to me. So I started doing research and rotations in med school, and I thought the technology was really cool and like it was a really cutting edge field. And I just really liked the people I met as well in PM&R. Yeah.
Thank you. Adil?
What's up, guys? I'm Adil, one of the R3s as well. I think I went into PM&R because my roommate at the time in med school stumbled upon it at a PM&R interest group meeting, actually. They had free food, so he went for the Chick-fil-A, but he came back learning about PM&R. And then we both decided to just try it out as an elective during third year and just fell in love with it. So that's kind of how things started for me. I'm planning on going into sports medicine. Yeah.
Great. Okay, did I get everyone? Okay, perfect. So I think then we'll go back around. And the next questions that I want to ask are, what other specialties did you consider before choosing PM&R? And then if you have a specific path you're going into or a fellowship or general PM&R, do you want to talk about what you love most about your job? And that can also be for general PM&R. So we'll go back around and I can clarify questions at any time. Brian?
Yeah, sure. So when I was in med school, I did think about orthopedic surgery because of its close relationship with musculoskeletal and sports medicine in general. But I definitely did not like the OR, like what it was required to be considered a competitive applicant. I did like I actually sleep like 6 hours, which is kind of low anyways, but apparently you have to sleep even less while you're applying orthopedic surgery. So that was one thing. And I didn't really like the OR environment. It was just kind of toxic to me. So I didn't fit well with that. After complete med school, I went into the military and I did an internship in internal medicine. And I was forced to consider a different career because there wasn't any PM&R options available. So I actually thought about internal medicine and then going into rheumatology because of their association with musculoskeletal diseases. I'm doing peripheral joint injections and whatnot. And it ultimately wasn't something that I saw myself doing long term, mostly because in rheumatology, you also have to consider like the vasculitis, the autoimmune diseases, and like all that weird stuff that we have to like learn in med school and then don't necessarily see a lot. So it didn't really excite me. One of the things was like, what gets my motor going? What makes me happy to wake up and kind of like show up to clinic? So I ended up doing like general medicine in the military and coming back ultimately. And with that experience in itself, reassured that sports medicine, musculoskeletal medicine is what I wanted to do. So I will also be pursuing a sports medicine fellowship because of all those experiences, I suppose. Yeah.
Great, thank you, Brian. Sarah?
Yeah, so I think I kind of touched a little bit on this with your previous question, but I did originally consider ortho, but kind of as Brian said, OR was not really for me. Also, I think I had a really positive internal medicine rotation, so I did consider that a lot. But I think kind of looking into it, I felt like everyone that went into IM, they kind of already knew like, oh, I really want to do it to jump to like cardiology or GI. And for me, I didn't really feel like a certain organ system was like pulling me a certain direction. And then I enjoyed neurology as well. But then I think I felt like my experience on neuro was they'd be diagnosing all of these like weird, things, but then kind of like after that, there wasn't really much that they were doing. So I feel like the function aspect for rehab was really something that drew me in. I think right now I'm, a second year, I'm still pretty early in my training. So I'm leaning towards sports, but I'm still pretty open. But I think like just within rehab in general, kind of, just seeing kind of the outcomes that you can see whenever someone comes to inpatient rehab unit and kind of when they discharge and kind of seeing their improvements is really encouraging and kind of not really something that you can see necessarily in like other fields where maybe the improvements are incremental or you don't even get to see them improve that much like on internal medicine before they're just like out of the hospital.
Thank you. Amar?
Yeah, I touched on this a little bit, but yeah, kind of my experience personally, losing an arm and then coming back and functionally improving with the prosthesis and seeing all the pretty amazing equipment that's out there that's available to help folks return to some previous level of function, especially if they've undergone some catastrophic event or had a stroke that's affected them pretty severely. And I do like some of the internal medicine side of it, but I wanted a little bit less of it. And so if you're inclined to do some internal medicine, but don't want like the full on patients of coming in with cirrhosis or doing a lot of that medical management, you can kind of get a mix of both worlds on the inpatient and consult side. It's a good variety of procedures, outpatient, inpatient. You get longevity of patient care, especially if you do some of the inpatient side, and then also have clinics, which is what a lot of our attendings do. So you get to see kind of overall improvement from spinal cord injuries and traumatic brain injuries, kind of long haul. In terms of procedures, attendings do joint injections, anywhere from joint injections to Botox for spasticity management, ITP pump refills, or baclofen refills to help manage with spasticity, and then spine injections. So it's pretty broad, and you kind of get to feel out what you prefer to do and get a mix of both inpatient, outpatient, depending on what you really feel you're inclined to do. It's very versatile.
And sorry if I missed it. Did you have a specific area of PM&R you're interested in going into?
I'm probably going to do more general, like neuro rehab, maybe a little bit of outpatient, although I'm less inclined.
Thank you. Allison?
Yeah, so I don't know if I really seriously considered that many other specialties. Probably would have done like internal medicine or peds if I hadn't done PM&R. I think I just wasn't as interested in the internal medicine material, and I think a part of it was I felt less passionate about kind of internal medicine, like treating numbers and labs, opposed to PM&R really focusing on patients' goals and their function. It just felt kind of less fulfilling to me. And then I think in terms of specializing after residency, I'm more interested in neuro rehab and inpatient side of PM&R. And if I did a fellowship, I'd be thinking about brain injury medicine, possibly spinal cord injury.
Thank you. Otto?
Yeah, so I guess I'm interested in sports medicine. That's something I've kind of grew up playing a lot of sports and got into bodybuilding and weightlifting. It kind of drove me towards like wanting to learn more about musculoskeletal medicine and the nervous system. So I think that's kind of what drew me to rehab per se. Yeah.
Thank you. Katie?
So I feel like everybody kind of said like a lot of the big things. I think it like very early when I was thinking about what I wanted to do, I thought I wanted to do OBGYN for like a second. I was like in the OBGYN interest group because I thought I wanted to like focus on women's health and all that. But ultimately, like for the same reasons as most everybody else, the musculoskeletal draw brought me to PM&R. I will say too, like as it kind of got closer to deciding what you were gonna apply to, I stumbled upon PM&R a little bit too through an interest group. But one thing that somebody like kind of brought to my attention was that there are still like a ton of fellowship options in rehab or like after rehab. And I think the only other specialty where you probably have like that much opportunity to specialize after residency is probably internal medicine. So I felt very much like I didn't totally know for sure what I wanted to do in medicine. I did know that I didn't want to be like managing, like chronic medical conditions. Like, I don't know, I just didn't enjoy that so much when I was in the hospital or when I was in clinics. But going into rehab, I knew I would like sort of the foundational aspects of it with the MSK and the neuro, and that there would still be opportunity to kind of like, I don't know, take a different pathway from there if something really caught my attention during residency. So I think that's something that's super nice about rehab.
Thanks, everybody. That's all really interesting to hear about. I think my next question, since everyone's kind of talked about areas they're interested and people have already touched on this a little bit, I want to ask for everyone, what conditions do you often treat or see attendings treat? And what kind of practice setting are you eventually interested in? Or have you seen attendings do that's interesting? So I will start with the people who are kind of interested in sports medicine. So to make sure I have that right, that's Brian, Sarah, maybe leaning towards that, Adil, Katie, were you also? No, Katie, yeah, Katie, you're interested in sports too, right?
Yeah, I'm like sports and spine, so it's kind of a little different, but pretty much the same.
Okay, so then maybe you and Allison can talk about your interest in spine a little bit together as well. But yeah, anyone who's interested in kind of answering those general questions, and I can repeat them or put them in the chat.
Well, as far as sports medicine goes, like my intent is to pursue like an outpatient career essentially in an academic center. Ideally then like have hopefully 50-50 admin, clinical like leadership stuff. Seeing a lot of patients every day kind of burns me out, but that's just something I enjoy, kind of working hospital systems and kind of getting involved into that aspect. But as far as like general sports medicine goes, like typical patients, you'll see a lot of low back pain, you'll see a lot of neck pain, you'll see a lot of shoulder pain and knee pain, less of hand and ankle pain. That's usually kind of how they come to us. And then you kind of do it, you essentially do an exam to kind of figure out what's going on. A lot of patients will come in with osteoarthritis, others come with like some sort of tendinopathy or tendonitis. And then you try to help them kind of manage their rehab. Depending on the setting that you are, if you're in an academic center like here, you don't really have to guide too much the physical therapist because they are really knowledgeable. But if you're in like a really either a rural area or a location that does not have a really strong foundation of physical therapists or occupational therapists, then you probably have to kind of guide that rehabilitation course by which exercises they should be doing, what precautions should be taken and whatnot. The unique part of PM&R, I think, also gives us an aspect into dealing with patients that have an underlying disability, either from stroke, TBI, whatever the case may be, spasticity, limb loss. And I don't think anybody else has that. So that's a unique perspective. And then we can also do EMGs in the sports medicine clinic. I will only touch base on like the bread and butter ones, which is the ones I intend to pursue, like cervical radiculopathy, lumbar radiculopathy, and bread and butter carpal tunnel syndromes. But I can definitely see like I'll let Amar speak on behalf of like more complex plexopathies that smarter people like to do. So I'll transition there. Well, actually, I don't know. I'll transition there.
Yeah, I can kind of give the flip side of it. So neuro rehab is more usually patients involving strokes or traumatic brain injuries with polytraumas, spinal cord injuries, and our job as physiatrists are to one, help sort of manage those patients medically. We're talking about bowel and bladder changes, neurogenic skin, spasticity management, um, but then also talking about things like prognosis. Do we anticipate this patient being able to walk again? What kind of equipment will they need going home? Power wheelchair versus manual wheelchair? Do they need a lift? We also work closely with our surgeons occasionally when they have questions about, how far down a limb do they amputate, to provide them with the most with the best functional outcome. I had a couple patients that had complete brachial plexopathies, and they had what we call flail limb, where they have no sensation or strength in their arm, and so they were recurrently burning their hand and coming in infected. And so getting a chance to talk to them about, what are the options for prosthetics, and what sort of function do we think we can get out of that. Those are kind of the big things. At Harborview, you're going to see, it's just a large trauma center, so you're going to see a lot of different polytraumas coming through. But then we also deal with kind of complex medical cases. Over at UW, you get more like patients that you're rehabbing for transplants, or patients who've had LVADs or been on ECMO. A lot of brain tumor patients that you're rehabbing, and so you're trying to coordinate when they're getting their chemo or radiation, and when the best timing for like recovery would be, and optimizing their functional recovery prior to or after they've had radiation or chemo. So it's a pretty wide variety of patient care, and I don't bread and butter that you're going to see in most community hospitals or private centers are going to be more kind of strokes or traumatic spinal cord injuries, and less severe traumatic brain injuries. But just because of how robust the UW system is, you get a lot more of the complex patients here.
Thank you. It was good to get the kind of general and neuro perspective, and also perspective in how UW might be different from other places, because that is, we can stay on this question if anyone wants to talk a little bit about spinal cord or any other type of PM&R, but otherwise we'll have two more questions left, and those questions are, how did you prepare to match into PM&R, and what do you think makes a good PM&R physician? And those will be our last two official questions. We can go on to just general questions. So I'll go ahead and call in people again. So Brian.
So what makes a good physiatrist? I mean, the only one thing I'll just say, you got to care. PM&R is it's so broad that right now, for example, I'm doing a rotation that I don't intend to do absolutely at all when I graduate. So I'm trying to look at it as, for example, what can I get out of this that will make me a better physician overall, whether that's interpersonal communication skills, understanding better the systems management aspect of it, or in my particular case, like traumatic injury. So I'm trying to focus more on like amputee stuff during this block particularly, and hopefully that helps me when I go into sports medicine and whatnot. But it really varies on which practice setting and what kind of specialty within PM&R you wish to practice, because even when you pursue general, it's so broad that you can even like hone in on specific topics within PM&R, within general rehab, and still not have all the breadth of topics that rehab, encompasses. And I'll leave it at that.
And what did you do to prepare for a PM&R residency? So like kind of how did you, when you decided that you were going to apply to PM&R, like, is there anything you started doing, like specific rotations, or did you do any research or other kind of contact with PM&R before you applied?
Yeah, so for PM&R, when I started preparing, I did an away rotation. I'm from being from Puerto Rico, I didn't have to, but I was in the Navy, so I suppose that I was trying to get an exposure and a lot of recommendations from a PM&R physician in that system, but it didn't work out that because they don't take Navy applicants, at least during my year. The other things that I feel like it's program dependent, and I want like everybody else to chime in, but for example, one thing that I always tell some of my mentees is, in a program like UW, for example, they do prioritize a lot, kind of a holistic CV, for lack of a better term, where you must show some interesting leadership, community involvement, and essentially systems management or systems like healthcare systems, in not just doing research, not just scoring high on the steps, even though that's changed now because it's pass or fail. But that is kind of how I went about it. I didn't do research when I was in medical school. I just did a lot of volunteer work because that's where I get my joy. I just like to help out and just be there. Research is something that I'm still working on and will probably not be as successful as other of my colleagues and friends. So I would just advise, do what you like. Because ultimately, if you're just doing something to boost your CV in order to get to a specific residency program, you might not be as happy or fulfilled. So that's all I got.
Thanks, Brian. Sarah?
Yeah, so I think, so for the first question, in terms of something that makes a good physiatrist, I think definitely being a team player is important. So, I mean, especially on the inpatient side, you're working with so many different fields. You're working with, all the therapists, nursing staff, and not even with that, you have, all of the subspecialties that you're collaborating with. For example, whenever we have like transplant patients, you have like everyone that's on the transplant team. So you have to, have the communication skills, and being a good team player is definitely really important. And I think in terms of things that I did for my application, so similar to Brian, I'm not that research heavy. I did do a little bit of research during med school. My school didn't have a rehab department, so I did stuff through ortho and the neurology departments. And then I did aways, which, I'm sure everyone does aways. I know that, if anyone's interested in rehab early, there are some good programs that you can actually participate in during your summer between like first and second year of med school. So AAP, the American Academy of Physiatry, has a summer externship. And then I believe Shirley Ryan, so Northwestern, also has programs that they offer. So those are kind of a combination of, you get to do early exposure to rehab related research, and you also get some clinical exposure too. So those are like awesome programs to look into if you want like early exposure to the field.
Thanks, Sarah. That's a good reminder. I'll put in the chat in a minute. We just have a short thing for people who are watching the video later on matching into PM&R residency, just like general things. And it includes opportunities like the AAP research experience. So thank you for that. Next, Amar.
Yeah, I see a common theme here. I was not big on research. I did a lot more volunteer work. But kind of since my program didn't have, or my institution didn't have a PM&R program, I did multiple ways. That's where I actually met Adil for the first time, and we matched together. So it's a small field, and I would say UW, for how big it is, has a very large network. And so tapping into that network can definitely be a boost for y'all. And trying to do any sort of research with any of the attendings who are all really approachable here and are always wanting extra help for their research. We could certainly pass on a few names and email addresses as well. But, you know, getting involved and staying and showing some interest is probably the best you can do. And networking.
Would you be willing to expand on networking, kind of what that looks like for medical students?
Yeah, I don't know if we have like a formal program, but certainly getting in touch with some of the attendings, either on the clinic side or the research side, and having a mentor in place would definitely help, especially early on. That way they can kind of get to know you and see how you're growing and how you're doing right from the start. And then just from that standpoint, getting you opportunities to get into clinic and seeing patients early on as well would be helpful. And then they could also kind of point you towards specific external rotations if that's something you wanted to do. A lot of our attendings or a lot of our faculty know folks in a lot of the different PM&R academic settings. That would probably be, I'm sure other people can expand on what they would do as well. But I don't know if there's an actual like official mentor for medical students program. If anyone else is able to chime in on that.
Dr. Lamb is like pretty involved with y'all's interest group, isn't she?
Yeah, so we actually do here at UW have career advisors for each specialty. And so Dr. Lamb and Dr. Lovelace are
Nice.
both of our career advisors. So for any UW students watching this later, getting in touch with one of them would be a great way to get involved. Thank you. Allison?
Yeah, and I think I was just gonna add, I think Lindsay, one of our co-residents, did like mentor medical students through an AAP program. So if you guys want to check out that website. Yeah, speaking of AAP, in terms of what I did throughout med school, I was pretty gung-ho about PM&R from the beginning. So I did the externship through the AAP that Sarah was talking about. So I did some research early on in med school, and also did some research during a master's year that I did in engineering. So I was interested in research kind of from the beginning. And I also was like involved in the PM&R interest group and doing kind of events like this and other kind of volunteer events of getting people interested in adaptive sports and PM&R fair. If you guys in the interest group haven't learned about that, there's a grant through the AAP that you can use to fund a PM&R fair. If you haven't done that before, it's really fun. Yeah, and I think I would also echo as much as possible trying to do away rotations, even if it's not like, people are like, oh, it's not like required in PM&R, but it's really good to see how PM&R is at different institutions and see how it is at a standalone hospital versus a rehab unit in a large hospital versus outpatient. There's so many experiences you can have in PM&R. So as much as possible, trying to have a wide experience in PM&R is something to help you hone in on your interests and talk about in interviews, and shows you're really interested in the field. Yeah, so I did a rotation in my home institution and a rotation here at UW when I was a med student. Yeah, and then yeah, I'm in terms of what makes a good physiatrist, I would just echo also what Sarah said. On top of everything that makes a good physician in general, in rehab especially, it's being able to work with a rehab team and use the expertise of all the therapists and nurses and psychology and everybody who's working together with you.
Thanks, Allison. that'll definitely lead me into some personal questions I have later about just UW residency and different away rotations and stuff. But continuing with this question, Katie.
Yeah, I think everyone said again, lots of great things. When it comes time to actually apply for residency, like a logistic thing, you'll need a letter of recommendation, I think, from someone who's like a physiatrist. So if you, I mean, you guys have rehab here, so you could just like rotate through us. But if you did want to go like to another institution and, you know, do an away rotation, I think it would be good to go somewhere, I guess, obviously that has like a residency program. I think that that's like a more valuable experience than maybe just like spending time in like an outpatient clinic, because sorry, the dog's chanting. You'll want to see like the dynamic of the residents and the attendings, and that'll be like the whole resident culture and experience, I think, will be really important. I'm gonna make that stop. So yeah, that would be one thing. And then as far as like volunteer opportunities go, I also like was not interested in doing research, and I preferred to spend my time doing outreach kind of stuff. So you probably know about Outdoors for All. I think that's like the easiest way to get involved around here. They weren't doing as much like the last year and a half or 2 years with COVID, but they're definitely, I think, back in full swing now. And that's like an adaptive sports organization. So it's kind of just like a fun way to get involved with the community or like the population that you would be treating when you're in rehab. And even if you do go into it thinking like you want to do pain medicine or like something outpatient primarily, so much of your residency is inpatient and like working with that more general rehab population. So I think it's good to know that like you feel comfortable in that space. So outreach events and things like Outdoors for All is a good way to sort of get involved. And then echoing what everyone said, I think the literal most important thing is being able to work in a team and to be a team player and to, you know, be a leader when you need to be, but also to sort of like know when to back off and let other people take the lead is something that you learn in rehab. Even if you don't get to do like too much rehab time, I think it's helpful as a med student to get some experiences with like surgical teams. Like at my med school, we had a lot of elective time. So we would try to do like 2 weeks with urology and like a couple weeks with neurosurgery. Because in rehab, you're going to be working with those specialists. So it's kind of nice to have at least like some idea of what they are doing so that when you're rehabbing them, or when you're like dealing with things that come up, you kind of have like some framework of what's, you know, what you're asking about. So yeah, I think that's what I'll add. Sorry about the donut.
Donut just wants to add their opinions, I guess.
Yeah.
But Adil?
Yeah, I'll keep this short. I mean, we covered a lot of ground with all the answers that we gave, but I think the big thing that I would encourage everyone, like as med students, is just do things that you enjoy in med school. You got to remember big picture, like we're in our 20s, like this is a pretty prime, you know, years of our life. We're all going to check the same boxes. We're all going to do a dab of research. We're all going to volunteer. We're all going to take our step scores. We're all going to get these grades, but like on interviews and, you know, when you're going around meeting people, they really want to see what you're passionate about and finding something that you like. If you do like research, okay, go into it. You know, that's what you like. Do as much of it as you want to do. If you like volunteering, do that. But I think the most important thing that I would recommend is just find what you like and just do it, like regardless of checking a box for your application. All this like teamwork stuff and like working with the team, like as a med student, I feel like I didn't really know how to talk to therapists or talk to other specialists. That's stuff you're gonna like learn in residency, but I think just remember that we're all doing this together. We're all checking the same boxes. This is all for like a job in the future, but you got to enjoy, you know, your time in med school and, you know, find stuff that you like to do too. So that's what I would recommend.
Okay, thank you everyone. That's the end of our official questions. if anyone's really busy, needs to leave, we're just gonna go on to any questions that I guess Joe, Katie, or I have. I know I had one, which was, what made you guys choose UW specifically for residency? And this is open to anyone who feels that they want to answer.
I can go first, I guess, because I was just talking. So one of the big things for me was the opportunity. So I guess knowing that I like sports, I was kind of interested in other things. UW has a lot of exposure to different specialties and different hospital systems. There's a whole nother discussion about inpatient rehab within a hospital itself versus like a standalone hospital, versus being in multiple hospitals around the city. I think, you know, the opportunities here to kind of just learn about what rehab has to offer was kind of the big drawing point for me. Another thing is, one thing I was pretty passionate about during med school and undergrad was volunteering at a kids camp. And so I spent a lot of time at this Serious Fun camp in Florida, and I found out that there's one near Seattle. So that was a drawing point for me. Yeah, so those are like the big things for me.
I guess I'll go second. I actually have family members here. I have a cousin. So among all the places that I interview, only one other location had family members. Everybody else in my family lives in Puerto Rico, essentially. So that was a lot of extra points there for any support that I might need. And then in between those two spots, for example, you'll come eventually, not now, this is not something you got to think about, but you'll come to have to think about whether you want to do home call or in-house call. And there's no right or wrong answer. Everybody has their own taste. I would rather, and I'd rather do home call, but I also did in-house call prior to having to make that decision. So I knew I didn't like it at all, or would rather not do it. And then as far as why UW in itself, UW has probably one of the most broad programs in the nation. It has a really unique patient population. You are probably going to be prepared to tackle anything once graduating here. And one of the things that I told myself when I was applying was, if I burn out and don't want to pursue a fellowship, I want to become the best general rehab physician that I can be. And I felt like UW provided me that opportunity and that network to succeed. So that also played a role. Thankfully, I've not burned out yet, so I'll be pursuing a sports medicine fellowship. So that's a good sign.
I think it's really important when you start interviewing and like meeting residents to try to get to know the people that are like already there, because I do think that the residency culture is like one of the most important things. And it's hard to tell once you like start interviewing because you only get to meet residents for like a short period of time. But those are the people that like you're going to be living it with for 3 or 4 years. And like, you want to know that, I don't know, you can vibe with those people. So when I was interviewing at UW, and again, it was different then, like we were traveling for interviews and we had like in-person happy hours and all that. But the people out here just seemed like they valued things outside of just their day-to-day job. And I think you'll find that in the specialty, like across the board, for sure. In my experience, UW and like some of these programs more out west really seemed to embody that like rehab physician lifestyle, where they really just like wanted to enjoy their own quality of life. So that was one of the things that like I considered when I was ranking. But looking back now, I mean, all you know is the experience that you have at the institution you match in. But I think, I don't know, I think you'll find like in the end, we're all kind of getting very similar training. UW has an awesome network, which is one thing that I'll say I'm really grateful for. We're like well connected nationwide. If you come to school here or residency here and then you want to get a job in New York City, like somebody here knows a guy there or knows a lady there. So the networking I think is probably unmatched. But for me, like the things like call and I don't know, for me that ended up being like less important. It was more about like, who am I going to be with? Am I going to be in a place that I like it's beautiful out here and there's so much to do when you're not working. So I think those things are important to consider too, because it's going to be a long 3 or 4 years wherever you go. You want to like where you are and who you're with.
Okay, thank you guys for answering that question. It definitely feels like a long way off, but it's cool to see what people were considering at that time and like what was important to them. Joe, Katie, do you guys have any questions?
Yeah, I have a question. So I'm entering my 3rd year, so the core curriculum clinical rotations. Do you have any specific advice for those and what I should be focusing on, or specific things that you focused on? Questions like that.
What is the core clinical rotations like consist of?
So psychiatry, internal med, OBGYN, surgery, peds.
Oh, you're starting your 3rd year. Duh. Okay, yeah. I think like 3rd year is exciting because like, even if you think right now you want to go into rehab, you might do a rotation somewhere like OBGYN and be like, oh my God, this is not what I expected, but this is what I love. So I would keep a pretty open mind 3rd year. I don't think I decided on rehab until like close to the end of 3rd year. I don't even think I knew about rehab until like close to the end of 3rd year. So you have time. So I would just, I don't know, embrace like every rotation and stay open-minded. Like don't pigeonhole yourself into rehab just yet. Like I think it's good to take things from all these experiences. And then like halfway through this year, you'll know like what sort of elective experiences you want, or you'll start planning that rehab rotation if you're still interested. That would be my advice. It's just really, yeah, keep an open mind.
Yeah, and also I would say like just in terms of rehab, like Katie was saying, like it's not helpful to pigeonhole yourself, but also you got to understand like that you're not going to like everything about rehab. There's things that each and every one of us here don't like about rehab, but there's something that we do find interesting and something that we do find we want to go into. So it's okay to not like every aspect of rehab, and those are things that as you go through 3rd year, you'll see like, okay, I like this about internal medicine. I don't like this about internal medicine or psychiatry or surgery or radiology or, whatever it may be. So I think it's just kind of taking pieces of the rotations you have and also taking pieces of the attendings you work with. I think that was a big thing that I learned during 3rd year is there's role models that I have that I take pieces of how they do things and I try to incorporate into how I want to picture myself doing things. And there's bad role models I have, and I said, I don't want to do what you did. And that's perfectly fine as a med student to understand that the way you're doing things is not the way I want to do things, or the way you're doing things is the way I want to do things. So as you kind of go through rotations, you're going to take pieces of good things and bad things to kind of sculpt that type of doctor that you want to be. I think that was kind of one of the biggest things for me during like rotations is just like understanding that, yeah, I got to try to like do my job and like get a grade from this rotation. But at the end of the day, it's all about sculpting this type of physician that I want to be.
Actually,
I'm gonna play a little bit of devil's advocate here. Like, let's say that you are totally convinced that you're gonna go to rehab. That's okay. That's okay if you made up your mind. Some of us did that. Obviously, you're not gonna show up to your rotation being like, "Oh, hi, I'm so and so. I want to go into rehab. I totally do not want to do OBGYN." Because that just it's like the wrong kind of learning culture. You're there to learn at the end of the day. And there's definitely something that you can learn from every rotation, whether that be things that are not necessarily what we get tested on, like the NDMEs or steps or whatever whatever exam you're taking. It could be from knowing how to talk to a mother who just gave birth and the baby passed away. Or I mean, I had a patient that was admitted to the hospital. We got consulted for inpatient rehabilitation, and she lost her baby after contracting COVID, and had a bunch of complications. And then we have to talk to her about getting into inpatient rehab. And we recently actually had a patient that pregnant, her baby did survive, and now she's in inpatient rehab. So knowing how to navigate those dynamics and be knowledgeable enough to kind of talk a little bit about things does help you in that specific example. So AAPM&R has a webpage that actually goes through what they think is useful topics within every specialty, like different specialties, cardiology, nephrology, etc. That you can maybe peruse and kind of take away. So that way, let's say that you're totally PM&R, you're struggling a little bit with how do I motivate myself other than just wanting to learn, then maybe using that could help you guide how you approach each different rotation that you're not necessarily going to pursue, if that makes sense.
That's I wouldn't have really thought about it from that perspective. Like the patients that you're going to be seeing are undergoing different things, kind of like what Katie was talking about, understanding neurology and urology and different things like that, understanding what they do, because you're going to see patients in that sphere. So good. I had a question. What has been the hardest? What do you find is the hardest part of PM&R for you? Like the most difficult, or the part that you like the least about PM&R?
Delivering bad news. We get a lot of patients who ask if they're going to walk again, and a lot of times other providers will beat around the bush, but at the end of the day, depending on what sort of spinal cord injury they had, or how severe their traumatic brain injury is, or how severe their stroke is, you got to have those conversations. And you always talk about hope, and down the line we'll see how you're doing, but based on kind of what we know about recovery, you got to have those conversations with folks. So and a lot of folks don't want to do them, or they give kind of the false hope of potentially, but very unlikely. So that's one of the harder things that I find doing.
I find that one of the hardest. Oh, go ahead, Allison.
Oh no. This is like maybe a smaller thing, but maybe related. I think also that reminded me, like one of the hardest things, I thought it was going to be like telling patients, oh, you're not going to walk, or you're not going to do this or that. But one of the hardest things I think is, from an inpatient perspective, telling patients you can't go home, and like telling them they need to go to a SNF or adult family home, and you can't live independently. And that also like leads to kind of a grind when you're a resident, of like trying to work with social work to like get patients out of the hospital when they're just stuck there. So it is a lot of like trying to navigate the healthcare system, and there is a lot of frustrations of like trying to get patients placement, trying to get them what they need, and when insurance won't cover their rehab stay, there is a lot of kind of burnout associated with that, I think, as a resident, when you're trying to like do that kind of scout work, kind of frustrating like social work. So it can be very fulfilling, but also it can be very frustrating.
That's kind of what I was going to say. So yeah, I'm not going to say anything.
Glad we're on the same mind meld there.
Yeah, no, it's exhausting. Like imagine trying to get a patient like an equipment that they need that will get them home safely, but insurance won't cover it. And then you're fighting. And we residents don't necessarily fight that much because we don't do the peer-to-peers, but it's exhausting. And sometimes not getting patients home, it's like, you know, it seems like a simple answer, but navigating the healthcare system is so complex that it literally sucks your soul sometimes.
I'll add something else. It's not necessarily the most like frustrating thing, the most thing I don't like, but one thing that I didn't quite realize when I was a med student is there's a lot of overlap in what we do as physiatrists with other specialists. So for example, orthopedics and neurology, even like general medicine. So sometimes like when we're at work and we're on rotations and seeing patients in clinic, we really like start to think like, what am I doing differently that this other provider is not? So I mean, again, it's like a learning opportunity for us to like see that patient and kind of dive into what the neurologic or other injury is, but the amount of overlap can sometimes get frustrating, and it really makes you question like why is this patient a physiatry patient and why can't you know just boundaries between specialties.
Yeah, I think part of that too for me is like half of us here really want to go into outpatient medicine, but when you're a rehab doctor, like you're doing some serious internal medicine type stuff too when you're managing patients on like the primary service. And especially if you come to UW, we're in the hospital and we have a reputation of being like a pretty strong program. So there'll be times where like I feel like we're a little bit taken advantage of as being good like regular medical doctors. And for me, that's frustrating because I went into rehab because I want to focus on like the recovery and the rehabilitation and the, you know, return to quality of life and all that. And sometimes you do get bogged down by like the things that personally I was not drawn to in medicine, like managing heart failure or like managing someone's diabetes or coordinating all of these specialists to figure out what we're going to do about an infection. And like those are all things that you're going to do in most, I guess, avenues in medicine. But it can be frustrating when like, you know, or if you know that your end game is not to be doing that, because you will do quite a bit of it in residency. So if you know you like don't like the medicine and you're like, oh, maybe ortho or something else, I think it's good to know that you're going to be doing a lot of medicine in rehab.
Thanks, Katie, and thanks, Brian, for putting that link in the chat. It's for recommended rotations for PM&R. Yeah, it's interesting hearing about the negative components as well. We just recently, as first-year medical students, had practice delivering bad news to actors, and it was very difficult. And so imagining doing that a lot in the daily, it's gotta be hard. But yeah, was there any other questions anyone had or anything anyone wanted to add before we kind of let everyone go? It looks.
Oh yeah, you got it. Joe has a question.
It looks like Joe through the chat said, can you describe the process of rehab for spine trauma patients and how do you work alongside the surgeons in this process?
You talk about spinal cord injury or like, I'm assuming spinal cord. Yeah, so usually we're not getting involved until after they've come in, had gone through the ED, had all their imaging, neurosurgery weighed in on whether they want to operate or not. There are programs out there where the SCI fellow is actually called in for any new concerning spinal cord injury patient into the ED to help manage that. But here at UW, it's usually kind of primary is neurosurgery or ortho spine who sort of determines whether the patient needs surgery. and initial sort of bowel bladder management and pain and all that. And then we typically get involved after they're kind of stabilized, usually after the first couple of days after surgery, or if they deem the patient's spinal cord to be stable in their and then we get involved and sort of help manage the sequelae of that. We try to get involved within like the first week. There's some prognostic indicators based on a clinical exam that we try to use to help assess where we think this patient will end up in terms of recovery. And so because of how robust our program is, neurosurgery and ortho spine is pretty aggressive about getting us involved early just to help with management. And then kind of long-term plan is usually to try and get those patients over to the inpatient rehab unit. So we are serially monitoring and assessing how they're doing. And as they're recovering, sort of make recommendations on when it's appropriate for them to come over. We also help with vent weaning off of, especially if they're high cervical spinal cord injury patients. There's sort of guidelines that we use to help get folks off the vent. And so that's also part of what we help with. I don't know if that completely answered your question, Joe.
Thank you so much for your time, everyone. I really appreciate it. I think unless anyone else has to add, we'll probably end the panel. So, thank you.
Thank you so much for organizing this. Hopefully it was helpful to people.
Yeah, it was really, really helpful. I definitely had like a lot of my questions answered. I also appreciate your guys' patience with the kind of last minute, the person who was going to be running it had an emergency. So we kind of improvised and you guys provided a lot of really great information. So we really do appreciate it.
Yeah, and feel free, I mean, I think I can speak for everybody to like send our emails out if anybody else has questions or wants to reach out. Like sometimes going through the resident is the most or the least intimidating way to get some answers. So anyone in our program will be happy to talk with you guys or people who are interested.
Thank you. We'll definitely pass that on. Really appreciate it.
Cool. Thanks, guys.
Yeah.
Thank you.